if we start with, say, the lifestyle behaviors, it seems like a lot of these cluster together in terms of low physical activity, higher rates of food insecurity or poorer diet quality, higher rates of substance use, so things like tobacco, illicit drugs. So, yeah, it seems like if you have one of these, you're more likely to engage in another one of these, and they contribute to that poor physical health outcomes.
That's exactly right. Yeah, we have turned it to the cycles of comorbidity, where this influences each other. Lack of physical activity may be because part of it has to do with lack of motivation that happens with some of the serious mental illnesses, which then influences your levels of engagement of physical activity, which then will impact your physical health and goes into this cycle of unhealthy behaviors. Same thing with like substance use, using it as a way of coping with some of the physical health or mental health issues that someone is having, and then engaging in those substances, which can impact their physical health and going round and round. So it's really these interactions between these different factors that really impact this, and it creates these complex problems for the population. And then if someone is not paying attention to their physical health, is more of the attention professionally is going to your mental health, and your physical health is not being managed or is not being paid attention to, then you're going to have serious issues as well. So those are some of the complexity of factors that come into play. And when you talk to clients and people with lived experiences, they don't talk about their health and their mental health. They talk about their being. That it's all one person, one human being. And in our system of care, particularly in the United States, we separate the health from the mental health, when in fact people talk about the whole body, the whole mind, the whole person, and our service systems separate those and create barriers for dealing with your health and your mental health at the same time. So that's the other component that also plays a role here. You have to go to different places to take care of your body or your health and your mental health with it.
So different people working in silos, and it's difficult to communicate with each other, these healthcare practitioners, right?
That's right. And it's left to the individual to make sure that that's being
Yeah.
coordinated. And you put on top of that psychosis, depression, and some other things, and it creates a real big issue. We call that fragmented care, and the person falls through the cracks in time. And this population is the one that tends to fall through the cracks more in this process.
Well, I can imagine that can be overwhelming, right? If you're dealing already with a serious mental illness, with the symptoms of, major depressive episode, to have to deal with coordinating different appointments, different medications, yourself, and essentially advocating for yourself to get your practitioners to talk to each other. I mean, that can be a challenge in itself.
That's right. That's right.
You've alluded to this a couple of times in terms of people who might have a serious mental illness and perhaps their physical health is overlooked. And again, referencing something that Oscar taught me in a previous episode, diagnostic overshadowing.
Mm-hmm.
Can you talk a little bit more about, what that might look like from an appointment point of view, from a practitioner point of view? Why would their physical health be missed, be overlooked?
That's a great component. So part of what's happening in a health interaction, so you can think of multiple factors that influence here, but a critical one is the interaction you're having with your provider. Like, how do you present the information, your symptoms, your complaints, your needs, and how the provider interprets that. And it's really interesting that when a person with serious mental illness goes and seek medical care from a provider that may not know them, so let's say they go to the emergency room, and the provider looks at sort of what are the critical issues this person have, and they see a mental diagnosis, schizophrenia, bipolar disorder, that tends to create a bias in the provider's mind, like, oh, this physical complaint that this person is discussing may not be a physical complaint, may be related to their mental health. So the provider creates this bias, and that's why it's called diagnostic overshadowing. The physical health overshadows, the mental health, overshadows the physical complaint. And in our work, we've seen that multiple times. We've seen that it's a common bias that providers have. And it's not that the provider is being rude, or that the provider it's not the I don't want to fault the provider here. It's just that in a clinical setting, you're making quick decisions. And if the person doesn't have the full picture of the individual, if the person doesn't have the right medical history, this could create some serious issues. So for example, we had examples of people going to the emergency room complaining of a stomach ache, like their stomach hurts, and they say, "Oh, that's on your head. That's not." And they see you're taking antipsychotic medication, you have schizophrenia. That's probably part of your. You're making this up, or that's not a real symptoms. And then, when in fact the person is having a painful reaction to something, they may have appendicitis, they might have something going on, and that gets overshadowed. So it's that interaction that creates this, and it's in the interaction between the client and the provider that creates these issues, and then creates to poor diagnosis that then could lead to the wrong treatment that the individual. So that influences that process as well. Yeah.
Yeah, yeah. And again, I think you alluded to this here in your response, but I imagine the environment with which the healthcare practitioner works in is important, in the sense that, at least here in Australia, our physicians, or as we call them, GPs, general practitioners, are very overworked. There's extremely little time to see patients. In fact, over here, mental health presentations are the number one category of presentations to primary care physicians or general practitioners by a long way compared to any other category. So to have the time to dive into the physical health component of someone presenting with a serious mental illness can be difficult if you're working in a stressed, overburdened system.
That's exactly right. So how do we support providers so within that system to address these issues? So providing them the right information, training them on how to create these interactions with people with serious mental illness can help in that overshadow. If the person comes with a family member who can advocate for their care, if they're coming with a healthcare manager or a case manager who knows the history and can provide that information, um, more clearly, can help with some of these structural issues in the environment that the provider is working on. The other thing is training general providers to work with people with serious mental illness in their medical school, in their training. Usually, when we train people in medical school for people with serious mental illness, they only see them in the hospital. They only see in inpatient care, which is usually, very important. Don't get me wrong, but it's a very different interaction if you're seeing that out in the community. So providing more training about working with people with serious mental illness can also address some of these issues.
And on that point, I know you've spoken a lot to patients, clients themselves. Have you talked to physicians as well? What's their opinions on their roles and what they need? Is it that they say that I do need more training, and that's what's lacking?
So that's one component. Yeah, in many of the studies, it's really important to understand all the different players here and their perspectives and their views on this. So, for example, we have a project right now with a great colleague in Puerto Rico, Elio Rivera Segarra, who's looking at diagnostic overshadowing and stigmatizing behaviors. So he's developed this wonderful training program where they're showing medical students, like, here's an example. Here's a video of a stigmatizing interaction between a doctor and a client, and they see, oh my god, this is what's happening, these are the issues. And then here's another example of a destigmatizing interaction. Here's what you should do, and let's practice it. Let's deconstruct that. Let's teach you the skills, and then they practice it with a standardized patient, so that they not only know about the knowledge of what to do, but practice how to do it. So that's one approach that providers can help with that. The other component is sharing information. In some of our projects, for example, we've used this idea of a personal health record, which is basically is your health record for yourself, and you can carry that. It's a little piece of paper. It tells you what your medical conditions are, what medications you're having, what are some questions that you may have for your provider, and that you can share that with the provider ahead of time, and so they can see what information you have. So that sharing of information can help reduce the diagnostic overshadowing and create a better interaction between the client and the provider, the patient and the provider, in some way. So there's ways to sort of doing that type of work that I think will be very helpful. The other piece
Mm.
here, it's from the other
Yeah.
side, which is from the
Okay.
mental health side of mental health providers like social workers or psychologists actually not paying attention to the physical health component. And part of it is because they're not trained on addressing the physical health issues. So you see this weird sort of dilemma of professional boundaries. You have a client, you're dealing with their mental health, they have a physical health complaint. Whoa, I'm not trained to do that. What do I do? That's not my job. I'm not trained to do that. So who's responsible for it? And then vice versa from the other side, a person with serious mental illness has a physical health issue, but is complaining of mental health issues. Who's addressing it? We call that professional boundaries. And part of that is that you have to work in a team together across different disciplines and different professions to address the needs of the individual. That also influences. So there's a lot of complexity in terms, but there's ways of addressing that complexity to address the whole person, the whole needs of that individual, to address this.
Yeah, that's really interesting. The side of the social worker or psychologist that you bring up, Leo, because I think even in my own training, this kind of information was largely not really relayed to us as future clinicians back then when I was training. So perhaps a lack of awareness, but also, like you said, a lack of and, not wanting to go outside your own scope of practice.
Yeah,
So most psychologists, social workers I know are really well-meaning. They get into the profession, they want to help people, but also you know don't want to. There might be a fear of not wanting to do damage or not wanting to go outside of your own scope of practice. And how do you overcome that?
that's right. And it's interesting. We've had the good example that we have here is that there's like a tipping point. So if you're a social worker, you have someone that you're caring for the mental health of that individual. But if there's an acute crisis, the person's having a heart attack, the person's is fainting, the social worker immediately, oh my God, there's a physical health issue here. We need to call the doctor. We need to activate. And for acute, immediate issues, we're very good at that. But what we're talking about is chronic illnesses, things that linger over time. So someone's hypertension, they might not have a heart attack in front of you, but their blood pressure might be up. They might have symptoms. And it's how do we move that tipping point towards more chronic illness management? That everyone in that team understands the person and what the symptoms are, what their needs are, and how to help coordinate and navigate that individual to the right providers, and how and providers talking to each other around these particular issues. That's one way that we have tried to address these professional boundaries, and look at it from a chronic illness perspective rather than acute issues that come up or just crises.